I'm Ryan Carlson with Health Jump, and I'm here with Hiren Doshi from Brilliant Care, and he's the Chief Executive Officer. Thank you for joining us today to talk about Brilliant Care.
Well, thank you for having me here, Ryan.
So my first question is, give me just a brief synopsis of Brilliant Care. Who are you and what customer do you serve?
Brilliant Care focuses on helping healthcare organizations proactively identify at-risk hypertensive and diabetics and essentially focus on population health management. And then we do this by using personalized nurse care coordinators with high-touch care coordination and advanced remote technologies. So we use this combination of these three to help take at-risk hypertensive or diabetics who are uncontrolled and bring them under control and essentially improve health outcomes.
That's fantastic. So are you working with accountable care for value-based side of things as well, for looking at the preventatives or to prove out those prevention plans? Tell me a little bit more, like some of the areas in the actual business that you're...
So essentially we serve practices, and this can be anyone from a small practice to a large practice, multi-specialty. However, greater application for this is by primary care providers, family medicine providers, geriatricians, cardiologists, endocrinologists, nephrologists, those subspecialties. Then we move on to ACOs, where ACOs are heavily focused on total cost of care, and they are always trying to see what can we do to minimize unnecessary ER visits, what can we do to minimize unnecessary hospitalization. And many of the things we do, in fact everything we do, is heavily focused on improving that access to care and preempting situations before they get escalated and nipping it in the bud, if you will. So that's how we help ACOs. And then with systems, the objective becomes a little different depending on what kind of system it is. It could be for their primary care facilities or clinics. It's the same agenda. However, they also have a need of how do you minimize readmissions? How do you take patients at discharge and provide them that enhanced care so that they don't show up back in hospitals?
So is this one of those programs where you're sending the patients home with either some sort of remote connectivity or some closing the loop service?
Exactly.
Okay,
so basically what we do is send patients home with remote devices based on the condition. So it could be a blood pressure cuff or a blood glucometer or a weighing scale. And based on the condition of the patient, the physician, the provider decides what's the most applicable one. And then a dedicated nurse care coordinator is assigned to this patient who's essentially ensuring compliance of physicians' protocols and ensuring that their vitals or readings are staying within bounds. And if they get escalated, then they triage them. That what's going on? Are they not complying with the medication? Are they not complying with the care plan? Or is it the treatment not working? And do they need to be seeing the doctor again so that something can be adjusted? So essentially, one way or the other, either by improving compliance and medication adherence, we get patient into better outcomes, or by changing the treatment plan, we get them to better outcomes. So essentially, we achieve success one way or the other.
That's fantastic. So that's supporting all those systems. Now, are you a referral from the primary care physician?
Correct.
It is. And so you're providing the nursing, and that's from your staff, right? Brilliant Care provides that oversight.
Correct. So we essentially act as a service provider. And we like to act as an extension of the practice to provide patient continuity of care. So we provide technology, devices, so both hardware and software technologies, and nurse care management. And that's the total package we provide, and then act as their service provider to deliver the service turnkey.
So I've had interactions with a lot of telehealth. My wife's actually a provider who does telehealth for mental health, and one of the challenges is when it's a referral and doing work on behalf of another practice is access to the records for the person that they're dealing with. I'd imagine that since you're logging all of these different vitals, are they logging into the practice EHR and then recording everything in, you said that like in-house, or how is that all being facilitated?
So we work directly with each practice's EHR.
Oh, great.
And in fact, that's where HealthJump comes in. HealthJump has been a great partner of ours in helping us integrate with EHRs so that we are accessing data directly from the EHR and posting it back into the EHR.
So you're taking advantage of the right back to put the remote the vitals and all of the information into the appropriate tables.
That is correct.
Okay, that's cool.
Yeah.
And then as far as the technology side, do you have a bunch of different partners that you're using? Because that home connectivity piece, I've seen it explode, especially with the pandemic, with all of the push to remote care. Are you seeing an uptick in adoption of the at-home monitoring?
All these devices which are available with different levels of connectivity. In fact, we use cellular-based devices. So our goal was, we deal with a population which is more older. As this is a Medicare CMS reimbursed service.
Grandma does not pay for high-speed internet. That's right.
Correct. So our goal was, and even then, even if they are willing to pay and even if they have it, they don't know how to connect with Bluetooth, how to pair. So we took all these devices, we specially picked devices which are cellular enabled. So when they get these devices at home, all they do is turn them on, take a reading, and the reading, it comes via cellular networks to us within 30 seconds. So it's seamless and it's very easy.
And so I imagine you're getting to intervene because it's not even waiting for the next visit. It can literally be, we can intervene within 30 seconds or do you prioritize the level of notifications?
Bingo. So what we do is not every reading is a crisis. There are different levels and we essentially treat them with a different level of priority. Urgent reading, then it means, well, attend to them right away because we could end up saving a life or preventing an unnecessary or an avoidable health emergency. And we've done many blood pressure reading, and if it's 200 over 120, there is a problem. If you pick up the phone and you triage it with the patient and they've not been taking their medication and maybe you can do something, or go, let's get you in to see a doctor before you get a stroke, right?
So I want to pivot to the accountable care organizations and some of the individual practices. You mentioned that you're actually going to help them look at their data. Are you able to then mine things and find, oh, here's everyone that hasn't had their A1C checked in the last 6 months, and here's a program that, are you making proactive recommendations on their behalf?
Indeed. So what we do is we mine this data and we look at everyone who's uncontrolled hypertensive, which is considered a blood pressure of 140 over 80, or A1C levels above 8. Some organizations look at above 7, and then depending on that, if patients had this reading last time they came, which was a year ago, and then you don't have a better reading, which means chances are they are still sitting at that level. So essentially we draw attention to a practice and we tell them these are the patients you need to be looking at. And if usually what happens is 20% of these patients who are uncontrolled are already scheduled to come in. And for them, what we do is we help draw attention by doing chart prep so that when a physician sees a record, they just see, okay, this is the patient who needs a little extra attention. And then the remaining of the patients who are not scheduled to come in fact, they are the bigger candidates for this enhanced service. So we tell them, here's your list. Let's attack this list. Let's call these patients in, and essentially by going in a very hyper-focused fashion, we're able to bring in the patients who would benefit the most.
So given that it's really hard, I hear this a lot from accountable care organizations, the ability to find groups or patient populations that are at high risk are really hard. With typically, if I wanted to look up information about an individual, I need to know their name, what practice they're at, and then request their A1C levels. So how are you getting around that challenge that the standards are kind of standing in the way of?
So it depends on the accountable care organization. So some organizations are well integrated where they do good consolidation of data of all their member practices, and the MSO plays or the ACO plays an active role in working with their practice. And others are loose associations of individual practices. It's easier to do this where it's the former than the latter. However, in both cases, ultimately, keep in mind, accountable care organizations ultimately depend on individual practice care centers. So really, they then recommend us to the care centers, and the care centers have to take a proactive role.
So because you are actually pulling the data, and you're getting all of the data, and you said that you're doing data mining, I suppose that means that's how you get to then run based on your partnerships with the individual practices.
Correct.
So you get to actually see that full data spectrum and run the analysis, and that's how you're actually able to go back from their own data. So that's actually really cool. It's something that not a lot of places are able to, based on my conversations with others. So
indeed, and that's where we saw the big white space where everyone cares about. If you look at it from a patient perspective, provider perspective, ACO perspective, or payer perspective, they all care about who are these patients who are at risk, who are going to either have episodes which are not going to be desirable from a experience of health perspective, or are the biggest worries of physicians. That's what keeps the physicians up at night, that what's happening to those patients of mine. Because if you go and ask a physician, you're at risk hypertensives, what are you doing about it? And the answer is, well, I address and attend to them as they show up. Can we change it? Because we have all this data. Can we proactively bring them in? And if we proactively bring them in, and then we improve their compliance and show them their reading, because if they see their readings every day, and if they get a reminder if they're not taking their medication every day, so we are putting them on a better course than they've ever been.
So do you have the big light bulb? And I imagine that you've got a lot of results. So is it a really positive picture? What type of results do you see with this early intervention?
So it's a great question. The results we are seeing is outstanding. It is so unbelievable, where in 90 days we see 85% of all patients who are on the program show clinically meaningful improvement in blood pressure readings. Go from uncontrolled to controlled in less than 90 days. An average drop for patients with blood pressure over 160 systolic is 30 points, which is a ridiculous number. So essentially what we are seeing, and this is just in 90 days, and by the way, the effects start as early as within 2 weeks, because what happens is in most cases, patients fall off, and our company's only goal is high patient compliance. So we have such high patient compliance, greater than 90%, because all our systems are designed around high patient compliance. That is our only single metric that our company cares about every day, that what was our patient compliance yesterday? And if it is below 90%, then we are like, why was it below 90%? And we are so hyper-focused on that. As a result, what we are seeing is these kind of clinical outcomes. So physicians who work with us are very happy, and healthcare organizations who we share this data with are floored. They are like, oh my God, is this really possible?
So what I love about everything I've heard is that you're taking healthcare data, you're getting the hard stuff that normally you can't get, you're leveraging it, but most importantly, it's not just leaning on technology, but it's empowering the human in the loop.
Yes.
That compliance is just like a personal trainer. You hire a personal trainer to give you accountability, and you want to do good for them. Right? It's the human touch, that human interaction that makes people want to do better. And so I love the work you're doing. Thank you for sharing your story, and we look forward to hearing from you in the future.
Thank you for having me.
Absolutely.
Thank you.
Take care.